run, we're very specifically focused on the medical and the prescribing elements, but we're going to do something slightly different today, and we're really going to focus on the role of dietary and psychological support to go alongside the use of the medications. Next slide, please. So I'm Neil Gupta. I'm Medical Director at Oviva. I'm a GP in London by background with a specialist interest in obesity and type 2 diabetes. Alongside working for Oviva and being a GP, I've spent many years working in NHS commissioning and was previously the chair of a CCG in North London. And that will be specifically relevant when we come on to talk about how you can help your patients access specialist weight management services. And I'm fortunate today, I'm joined by two fantastic colleagues, Juliet and Vicki, and doubly fortunate because they will be doing most of the hard work today. And I will let them introduce themselves when we come to their sections. Just a quick note that we are recording the session. Hopefully everyone is okay with that. We're going to aim to finish around 12:45. Ideally, we have a little bit of time at the end to take some questions. So there is a Q&A function running, so please do pop any questions you have in the Q&A section. If we don't get a chance to answer those today, we're very happy to respond in writing. Next slide, please. So just to kick off a little bit about Oviva, because I'm sure there are some people on the call who are not familiar with Oviva. We deliver services for people living with weight-related conditions, so primarily obesity and type 2 diabetes. And that includes being part of the NHS Diabetes Prevention Programme, being part of the National Diabetes Remission Programme, and specifically relevant to today, that includes the provision of Tier 3 weight management services in the NHS in both England and Scotland. What makes us slightly different is that we deliver the bulk of our care remotely. So we do that through telephone appointments, video appointments, or digitally through the Oviva app, as opposed to more traditional in-person, face-to-face appointments. And what's really important to stress, though, is that we only deliver NHS services, so we don't have any private self-pay weight loss services. Next slide, please. And this slide just gives you an idea of our history and our coverage. But I think really just focusing on Tier 3 services, we've been delivering Tier 3 weight management services in the NHS since late 2017. And in that time, we've received well over 10,000 referrals to our Tier 3 service. Approximately getting close to 3 years ago now, we embedded the use of GLP-1 medication into our Tier 3 weight management pathways. Next slide, please. So really the aim of today is to hear from two of our most experienced Tier 3 clinicians, Juliet and Vicki, to talk about the use of these medications in the real world. And as I've said previously, the aim is not to focus too much on the medical and prescribing elements, but instead to focus on the support offered by our dietitians and psychologists within a Tier 3 service. As GPs, we are regularly seeing people coming to us asking about these medications. Perhaps they're actually already on the medications either through a private service or through an NHS weight management service. But many of us as GPs will have received little or no training in the management of obesity. So really the aim of the session is to come away feeling more confident in having those conversations with patients about these medications, about the role of dietitian and psychologist input, and just generally about Tier 3 services, even if you're not actively involved in delivering the obesity care yourself. So just starting with this slide, I think it's always important to set the scene and talk about why it's important to treat obesity. And this slide just captures the health consequences and also the financial consequences of obesity. And much of this, I'm sure, will be familiar. So on the left-hand side, we have the very well-known association with type 2 diabetes. Just below that, perhaps sometimes less well appreciated, is that obesity is a significant risk factor for many of the common cancers. And that includes cancers like breast cancer or bowel cancer. And obesity is really second only to smoking in terms of significant cancer risk factors. But obesity is linked to a whole host of other diseases, and many of those are very familiar, things like heart disease, strokes, type 2 diabetes, fatty liver disease, that occur through the metabolic consequences of obesity. But obesity also has very significant mechanical consequences, and that can result in conditions like obstructive sleep apnea, gastroesophageal reflux, and osteoarthritis. And then finally, and again, perhaps sometimes less well appreciated, is that obesity has very significant psychological consequences. And there is a very strong bi-directional relationship between obesity and common mental health conditions like depression and anxiety. And if we look then on the right-hand side, not surprisingly, given the significant impact on the individual, obesity has a significant impact on the health service and the wider economy. So it's estimated that overweight and obesity together cost the NHS nearly £20 billion a year. And the cost to the wider economy, for example, through absenteeism at work, is closer to £100 billion per year. Next slide, please. So we know that obesity is hugely damaging for the individual. We know that it's costly for the NHS and it's very costly for the wider economy. And we now know that we have very effective treatments for obesity. But when we look at the service landscape through which to deliver those treatments, we can see that it's a mess. And we've known this for a long time. Generally, access to tier 3 weight management services is generally poor and it's highly variable. So it is the classic postcode lottery. And if we look at that just purely through the lens of NICE's eligibility for Wegovy, you can see on this slide that NICE estimates that approximately 4.2 million people are eligible to receive Wegovy from the NHS in England. But NHS England recently estimated that there were just 35,000 places annually across the whole of England in tier 3 weight management services. So you have 4.2 million versus 35,000. So there's very clearly a huge mismatch between the need in the system and the capacity in the system. And I'll talk right at the end of this session about what we're doing at Oviva to try and help tackle that shortfall in access to specialist weight management care. Next slide, please. But I think it is also important to appreciate why we've ended up in this situation. Why have we ended up with such a shortfall in capacity in the services that we need? And ultimately, the root of that is attitudes. And attitudes remain the single biggest barrier to getting weight management services right. So I don't believe there is any other area of healthcare or medicine where that level of shortfall in services would be deemed vaguely acceptable. And so it's important to recognise that still not everyone believes that we should be treating obesity medically. And that includes some clinicians, it includes senior NHS decision makers, and it includes politicians. And for those of us who work in this space, we are still very regularly having to make the case that obesity is not a lifestyle choice, that it is not about being greedy or lazy or both. And actually, obesity is not just about crossing an arbitrary numerical threshold of having a BMI of over 30. It is far more complex than that. And there are lots of definitions out there, but there is one on the right-hand side of this slide that I like that starts to try and capture some of that complexity. And it defines obesity as a chronic, progressive, relapsing and treatable multifactorial neurobehavioral disease. And I think that's helpful because it starts to help guide our approach by highlighting the complexity of the condition, but also stressing that obesity is treatable. Next slide, please. Okay, I'm not going to spend too long on this. This is really just to do a quick recap on the medicines. I'm not going to spend long, firstly, because that isn't the focus of today, but secondly, because we're also running a webinar specifically on this topic next Thursday, which will dive deeper into the medications, in particular with a focus on tirzepatide and the difference between the two agents here. But let's do a very quick recap. And in terms of the medications, we're really interested in two medicines at this point in time: Wegovy, which is semaglutide, and Mounjaro, which is tirzepatide. Saxenda, which is liraglutide, is still out there, but it's rapidly becoming obsolete. It's a daily injection, which does not achieve the same levels of weight loss as these two agents. Both of these medicines are given by once weekly injection. Both are approved for weight loss by the MRHA for licensing. And I can now say both are approved by NICE for use for weight loss within the NHS. Mounjaro, very recently, this was December the 23rd, I think, just before Christmas, received its NICE approval for use within the NHS for weight loss with very similar and similarly broad criteria as Wegovy. Wegovy, semaglutide, is a mimic of a naturally occurring hormone GLP-1. There are lots of GLP-1 receptors all over the body, but the receptors we're particularly interested in are the ones in the brain. And by increasing GLP-1 activity within the brain, we can promote satiety and we can reduce hunger drive. And that is the primary mode of action of these medications. Mounjaro, tirzepatide, also works on the GLP-1 pathway, but it also works on an additional hormone, GIP. So it works on two hormones. It is a dual agonist. And as you might expect, as a result of working on two hormones, it is showing that it is more effective in terms of absolute weight loss compared to Wegovy. Next slide, please. So how effective are these medicines? Very quick summary on that. This slide just captures a summary of the key clinical trials for these two agents. And if we look at the left-hand side and we look at Wegovy, the key clinical trials were the STEP trials. And in really simple terms, the average weight loss for people receiving Wegovy was 15% or over 15%. But actually, if you look at the darkest green bars for the Wegovy chart, you can see that around a third of people actually lost over 20% of their body weight. And that really was groundbreaking and astonishing because that is the sort of weight that you would be looking to achieve through bariatric surgery. But if we look over on the right-hand side and we look at Mounjaro, we can see that the average weight loss in the SURMOUNT trials, which is the equivalent of the STEP trials, but for Mounjaro, the average weight loss was over 20%. So, absolutely astonishing results in these trials, and really the sorts of levels of weight loss that we've only ever previously seen through bariatric surgery, which is the reason why many of us are getting excited about these medications. Next slide, please. Why is that important and why do we get excited about that weight loss? Well, 15 to 20% weight loss is a life-changing amount of weight loss. If we can help people to lose 15 to 20% of their body weight, we can have a very significant impact on their overall health. So we can prevent the occurrence of many conditions like cardiovascular disease, but we can also reverse established disease, things like type 2 diabetes, non-alcoholic fatty liver disease, sleep apnea. And actually, you can see on this slide, there are lots of trials going on at the moment looking at these agents and their impact specifically on each of these comorbidities. In particular, I would highlight the SELECT trial, which showed that Wegovy can result in a significant reduction in cardiovascular disease. So the endpoints were heart attacks and strokes can result in a significant reduction in those in people with existing cardiovascular disease living with overweight or obesity. And that was a really important trial. Next slide, please. Okay, final slide from me, and really just coming back to that point about how complex obesity is. And we talked about that chronic, progressive, relapsing, multifactorial neurobehavioral disease. And this diagram is taken from a government report from many years ago, and you're not supposed to be able to make out all the individual lines, but it just shows all the systems that are in play that are driving the energy imbalance that results in obesity. And given the complexity of the condition, it is wishful thinking to think that a drug alone can tackle the condition of obesity in itself. It is absolutely, what this diagram says to me is that it is absolutely essential that even though we have these drugs, it is absolutely essential that people continue to receive holistic obesity care and that people continue to receive multidisciplinary support, not just from doctors and nurses, but also from dietitians and psychologists. People living with obesity often have a significant degree of medical, psychological, and social complexity. And with that, I will hand you over to Juliet.
Thank you, Neil. Hello, my name is Juliet Finny. I'm a dietitian and clinical lead at Oviva within our Tier 3 weight management pathway. And what I'd like to speak about today is some of the detail of how we support our patients at Oviva who are taking these GLP-1 medications, some practical tips on how to support patients to optimize their nutrition, and manage side effects of the medications, and then share some of the insights that we've gathered along the way as well. Next slide, please. So as part of our pathway, we can prescribe Wegovy for up to 24 months according to the NICE TA. And during that time, that prescription time of 24 months, we support our patients closely with diet, lifestyle, and Vicki will tell you about the psychology support within that as well shortly. It's really, really important to us that we provide that tailored support throughout the whole of the pathway. And the other thing that's really important is that we start planning for medication offboarding from the beginning. So we're limited within the NICE TA for Wegovy prescribing to a 24-month prescription, which means that our patients will reach a point where they will stop taking this really effective treatment. It's really important to us that we plan alongside our patients from the beginning how they're going to manage that transition to stopping the medication and to that long-term approach to maintain all of those benefits that hopefully they will have achieved during that treatment pathway. So we start planning that from the outset, as well as individualized, tailored support, dietary approaches, and we'll talk about the practicalities of that in a moment, exercise advice, but then also thinking about that longer term and managing those challenges in the longer term. And we'll plan for that throughout the pathway, with ramping up that advice and support for the offboarding towards the end of the pathway as well. We also make sure that we are providing advice around exercise and goal setting, and from an exercise point of view with a specific focus on strength and resistance training. And the aim of that is to optimize the health benefits associated with that, and specifically to look at maintaining that lean muscle mass as much as we can and minimizing the loss of lean muscle mass. So we do that from both a nutritional and an exercise point of view. We also have a pathway available for patients who either don't qualify for GLP-1 treatment or who don't wish to take up the offer of GLP-1 treatment. And Neil's just run through all of the benefits of the GLP-1 treatment, but it's not for everybody. There are people with medical exclusions, and there are people who prefer not to take up that treatment. And there are also people who may start on GLP-1 and for some reason can't continue, whether it's for medical or other reasons. And it's really important to us that we support those patients, whether they're on the GLP-1 or for whatever reason they're not on the GLP-1 treatment. We still can offer that tailored, individualized dietary support and advice to help people to meet their weight loss goals. And we work really closely within an MDT team with our dietitians, health coaches, and our psychology team as well. Next slide, please. From a dietary point of view, one of our really key focuses is on nutritional quality. So Neil's already mentioned that the key action of the medication is suppressing appetite. So most people feel a lot less hungry. They feel a lot less driven towards food. They experience fewer cravings. They think about food a lot less than they did before. So there are multiple advantages to that, and that's essentially how the drug works and how it brings a lot of its benefits. But there are disadvantages too, in that it can be easy to fall out of the habit of regular eating. People may be less inclined to eat balanced meals and more inclined to have quick snacks. And there's fewer opportunities to get the nutrition that the body needs if you're eating less and you're eating smaller amounts or less frequently. So our key role is to switch the focus towards nutritional quality and establish a regular eating pattern of small, nutritionally balanced meals that support our patients to get all of the nutrition that they need. And this can be a really positive move and a really big shift in mindset from many people living with obesity have had years, if not decades, of a life of swinging between restriction, perhaps that then resulting in overeating, trying many, many different dietary approaches in the past, which tend to be based on restriction. And this is now a focus where they can stop thinking about restriction and start focusing on the nutritional quality of what they're eating. So it can be a real positive change in mindset, but something we need to really support closely in order to help our patients to do that in the right and the most beneficial way. So we're looking at every time you're eating, seeing this as a potential source of nutrition. What nutrition can you gain from this, even if it's a small portion? Can we make it balanced? where are the sources of protein, and protein is one of the real main focuses of the advice and support that we give. And partly that is for the overall nutritional balance, and partly that is for protecting that lean muscle tissue during the rapid weight loss associated with the medication. So we recommend protein at every meal. We recommend following what we call the T plate, so at least a quarter of the plate protein, half a plate vegetables, about a quarter of a plate carbohydrates. In most cases, we don't recommend protein supplements, so you can get enough from dietary sources. But when our patients are choosing snacks, we'll encourage them to think about, again, nutritional quality, protein-based snacks. And all of this focus on the protein aligns really well with overall nutritional quality. So usually when you're focusing on protein sources, you're moving away from those kind of empty calorie snacks and grabbing things like, for example, crisps and biscuits to get you through the day, moving towards a higher nutritional quality in both meals and snacks. Next slide, please. So the other aspect of our dietary support can be around side effect management, and with frequent and personalised dietary support, many side effects can be managed in the early stages without the need to escalate to medical management. So that's a key role of our dietitians as well as our health coaches on our pathway. And two of the key side effects that we help to support manage are nausea and fullness and constipation. So if we start with nausea, as we've mentioned, appetite suppression is a key action of how this drug works. And for some people, that will then tip into experiencing nausea. And it really depends on the extent of the symptoms. So is it fullness that is helpful in terms of controlling intake, or is it nausea that's impacting on quality of life? And therefore, we need to do something to manage that nausea and keep it under control. And the things that we'll look at are meal timing, spacing meals out. Again, it aligns well with our regular eating approach. We'll look at the timings of fluid and perhaps having fluid between meals rather than with meals to limit that sense of fullness. We'll look at reducing fatty foods, fizzy drinks, in some cases spicy foods, and limiting alcohol. And again, all of this aligns really well with the nutritional quality focus that we're taking. And then if needed, we can escalate that, but often these first line approaches to managing side effects can be enough to keep these under control. Constipation is another really common side effect on these treatments. And we'll look at nutritional quality, and that in itself can help to prevent constipation. But we'll take a focus on fluid intake and make sure that we're optimizing fluid intake and aiming for the 30 grams of fiber target per day. And these are all really good strategies, both for long-term dietary approaches and that long-term approach to preventing weight regain, as well as managing these side effects in the here and now. We'll talk about physical activity, and we've mentioned that exercise is a focus. And a lot of people don't realise that physical activity can really impact on their digestive function as well. So we support with that messaging. We can recommend fibre supplements if needed, but often with that focus on dietary quality, moving towards fibre-rich and protein-rich snacks and meals, and that tea plate with at least half of the plate filled with vegetables is enough to keep these side effects under control. Next slide, please. So I wanted to just finish with a few insights from our practice of working with our patients from a dietary point of view. In our experience, most people who are on these treatments are also really keen to make the impactful dietary and lifestyle changes at the same time. So most people see this as an opportunity when they access this treatment, and they see it as an opportunity to make the most of it. And we work really closely with people to explain that these drugs are effective, but you can make them as effective as possible by doing the diet and lifestyle changes alongside. And most people are really very much on board with that and really keen to maximize this, what they see as a real opportunity to access this treatment. So it makes it a really motivated patient group to work with, and we can see some really impactful changes, which is really meaningful. As I mentioned earlier, the planning for the medication offboarding is essential. So nobody wants to be surprised at the end of the pathway that their appetite is going to increase again when they stop the medication, or that the medication is going to stop at all. So we need to plan for that 24-month medication stop, and we do that, as I say, from the outset. That needs to be the basis of, this is an effective treatment for 2 years, but also let's think about the long term. Let's think about your strategies, your challenges, and your toolkit for managing those challenges right from the beginning. and ramping that support up towards the end of the pathway as well. Achieving effective weight loss can be extremely motivating, and it's absolutely fantastic to see the results in some of our patients who, for the first time in perhaps forever, they see really impactful, effective weight loss. After years of challenges and maybe losing a little bit of weight and regaining the weight, this may be the first time they've seen some really effective, real results with their weight loss. And for many people, that is extremely motivating to then carry on in a positive cycle of making more lifestyle changes. They feel better about themselves, it increases their self-efficacy, and that then can result in that really positive spiral. So the weight loss in itself can be an extremely motivating thing to see, and we're there to support that, doing that in the right way and looking at that holistic health at the same time. And as I mentioned before, it's that switch from the focus on restriction to nutritional quality, and it can be such a meaningful conversation to have with our patients about that switch in mindset, and it's a real pleasure actually to support them through that journey and that change in mindset. And lastly, for us, it's really important that we work so closely together. So our psychology team and our dietetics team talk to each other all of the time and work really closely together to manage our patients and give them the right level of support, so that the advice that our psychologists give is aligned with what the dietitians doing with that patient at the same time, and working within that wider MDT and linking in with prescribers and our medical team as well. I think it's essential for our patients to get the most out of that treatment. So with that, I'm going to hand over to Vicki, who's going to tell you a little bit more about our MDT working and our psychology input. Thank you, Vicki.
Thank you very much, Julia, and great to be here today. Hi, everybody. As mentioned, I'm Vicki Lawson, and I'm the clinical lead for psychology at Oviva. Next slide, please. So, picture of me up there. You can see better than this slightly gloomy camera angle I've got on the moment for some reason. But there's two of my colleagues, both psychologists, senior psychologists, Jordan and I, Kavina, and we're also supported by a large and ever-growing team of psychological wellbeing practitioners. Next slide, please. So within psychology in our Tier 3 programme, we take a stepped care approach. So all patients are offered some level of psychology input, and I'll talk a little bit more detail about what that looks like. But we very much titrate the level of intervention and what we offer to people. And obviously, we've got some people within our service who have very complex medical, psychological, and social needs, as Neil mentioned earlier. And so we make sure that we gear most of the sort of senior psychology team time, for example, around those patients, with other patients supported by PWPs or guided self-help. And we also very much want to take into account, of course, patients' preference about how they want to work with the psychology team, and indeed if they want to work with the psychology team. Glad to report that most of them do, and also to avoid overloading patients with too many appointments as well. Really important to us, so that it's very much a patient-centered approach. Next slide, please. So what does that look like in practicality? Well, we offer, as I mentioned, guided self-help. We offer app coaching. We offer telephone and video coaching with either a psychological wellbeing practitioner or a clinical psychologist. But before that stage, we also have a very rigorous screening process in place to decide both at what level we triage to, but also is everybody suitable for our service. So we ask patients to complete a whole raft of questionnaires when they first join us, self-report questionnaires, and included in that is other questions from the PHQ-9 questionnaire, you're probably all very familiar with, around depression. And we also ask patients to fill in a self-report binge eating disorder screening survey. So with mental health, we don't exclude anybody on diagnosis, so we will take anybody regardless of their mental health diagnosis, be they secondary care or primary care level. So whether they've got serious mental illness or more primary care, sort of anxiety, depression type condition, if at all. But what we do look for is stability. So we don't take patients, for example, who are actively suicidal. We don't see this as an appropriate service for those patients. So we refer patients back to their GP until stable and making sure that they've got lots of support in place, and then we would be very willing to work, as I say, with anybody. And we also are looking to identify patients that are at risk of eating disorders, and most commonly in tier 3, that is of course going to be binge eating disorder. The binge eating disorder is a contraindication in the NICE guidance for treatment with weight management interventions. So we are looking to screen out patients with binge eating disorder. And we don't diagnose binge eating disorder, but we are looking to identify and then refer back. And how we do that is, as I say, a self-report sign-up survey when people first join us, and then all people who come onto our service who meet the sort of the minimum criteria, either of PHQ-9 or BED, will also have a psychology initial consultation, not dissimilar to the dietetic consultation, to help with us assess risk. And then based on that, we bring people to a separate MDT if needed, which then considers if there is a need for further assessment within an eating disorder service, for example, and would refer back to GP if that was the case. So we are, again, Juliet mentioned sort of differences between the sort of private prescribers and sort of NHS providers like ourselves. And I think this is a really crucial difference from a psychology perspective. We are looking at patients who've got a lot of complexity, a lot of trauma, and it really isn't a case of one size fits all. We need to bear the patient's best interest in mind and do a thorough assessment before letting people embark on the programme. Next slide, please. So in light of the GLP, so I've been at Oviva for getting on for 4 years now, and obviously we've had the change to providing GLPs. And in light of that, I just wanted to share a little bit about how our practice in terms of identifying risk has changed, and also how we deliver the psychology sessions. So I think before we had the GLPs, we were much more cautious, and perhaps overly cautious, about binge eating disorder risk. And I think now we have reassessed that because of the impact of GLPs on binge behaviours. So whilst we are still very cautious, and we would always want an assessment in an eating disorder service for somebody who we thought had binge eating disorder risk, for somebody who is binge eating, we are maybe a little bit more flexible because of the impact of the GLP on probable binge behaviour. So that is a slight change for us. And then the other sort of significant change is that we now have psychology sessions split between year 1s and year 2. And just as Juliet was saying, it's really important for us that the offboarding is just right. So we want to make sure that patients have behaviour change techniques in place, that they have relapse plans in place, that they are good to go when they come to stopping the medication with us. And that's very much in mind that, you know, obesity is a chronic disease, and so we do need to treat it as such. And so having relapse plans in place is absolutely vital. So what does our psychology service actually look like? Next slide, please. So what we're trying to do within our programme is working very much, as Juliet says, in tandem with the dietitians, and we very much support each other in the goals that we have set collaboratively with our patients. And we are looking to use this 2 year on GLP medications as a real window of opportunity to embed sustainable behaviour change, to get everything in place so that when people stop, the habits and the behaviours that were driving the eating behaviours previously, they've had an opportunity to change those, so that they can really look at fostering sort of long-term habits, which is going to support health in the long term as well, of course. And also helping patients to start to reassess their relationship both with their bodies, with their weight, and with their food. The changes that Juliet and her team work on with patients in terms of improving nutritional quality, we're also there to support that as well, because that's quite a significant mind shift for a lot of our patients, to move from this constant monitoring on the scales in a very anxious way, and also from a sort of restrictive pattern of eating, and then sort of a boom or bust, so restriction, then overeating. So helping people to navigate their way through is a very new life for a lot of people. And we also see this 2 years on the medication as a window of opportunity to help people to really step back and think about what are the psychological issues that have been underpinning some of the things that have been driving their eating behaviours, some of the things that have been restricting their physical activity behaviours. And we can support them within the psychology team, but we also like to use this time It's a time to help people get support elsewhere for issues that don't maybe directly sit within our remit. We spend a lot of time supporting people to access local talking therapy services, for example, and actually start addressing some of the real underlying issues that they've been struggling with in many cases all their lives. Next slide, please. And then I just thought I would also share some insights from what we're seeing from a psychological perspective on the impact of GLPs. And I think this reduction in the food noise, I put it as the first bullet point, and there's a reason for that. That is the number one thing I'm hearing from patients, and it's absolutely fascinating. The patients are just reporting that they are getting such a significant reduction in intrusive thoughts about foods. They're not waking up in the morning and thinking, what can I eat today? Where can I eat it? How will I feel afterwards if I do eat it, and having concerns about that. It's not this constant noise around food. And I ask patients what that feels like. What does that mean to them? And so many of them find it very hard to verbalize, but are talking about it's just peace for once, and it's giving them space in a way they haven't had space for many, many years. So that's been, I think, one of the most significant changes that we see. Also, we are seeing shifts in appetite and food preferences. So while our dietetic team are very much there to support patients, and that is having a massive impact, what we're also seeing is that the GLPs are having an impact in terms of people having less liking for sort of sweet and fatty foods. And that is borne out by the literature as well. So really interesting how appetite and food preference seems to change. And we are also seeing this as a ripple effect into other areas. So we are having people who are, without our input, massively reducing alcohol consumption, stopping smoking, using healthier coping mechanisms. So a whole raft of positive changes in that area as well. We're also seeing that patients that were maybe binging occasionally, that this is reduced massively, and people are less likely to use food as an emotional coping strategy as well, and are seeking more helpful coping mechanisms. And again, this is why it's so important to have psychology there, so that we can actually, our team can actually be there to support people about making those changes. And so overall, I'd say what we're finding is that our job has just got a bit easier. Behaviour change has become more manageable for people, and people are reporting improved well-being. And very much as Juliet says, we seem to be getting, for once, we're getting a virtuous cycle and very much in the direction that we want people to move towards. And they're having this space and time to really make these changes and embed them. So yeah, very interesting times. Thank you very much. That's all from me. Hand back over to Liam.
Thank you, Vicki, and thank you, Juliet. That was great. And I think, as both of you have alluded to, it's very much an evolving area in terms of the dietetic and psychological support that is needed to optimize outcomes alongside these weight loss medications. So it's a really exciting time, I think. I just want to finish the last few minutes just talking about how you can help your patients access Tier 3 weight management services. So we'll start here, which is just the eligibility criteria for Wegovy, which I'm sure many people, if not all, on the call will be familiar with. It's very inclusive. Essentially, you need to be living with obesity and have one weight-related comorbidity. And the challenge is that NICE stipulated that Wegovy could only be accessed through a specialist weight management service. And as we've talked about earlier in the session, there just aren't those Tier 3 weight management services available to most. And so what that means, and we see this in practice as GPs, what that means is a lot of people who stand to benefit from these treatments just simply have not been able to access them. Most people can't afford to pay privately for these treatments. A small minority can and do. So we are seeing lots of people accessing these treatments through the private sector. But what I would say is practice is, if I'm being kind, practice is quite variable in the private sector. Certainly even in terms of the medical elements, but all of that dietetic and psychological support that Vicki and Juliet have outlined is mostly absent in that, and hopefully we've helped make the case as to why that is absolutely essential to try and achieve lasting long-term outcomes for these patients. What we don't want to see is people taking the medications for a short period, which is very common in the private sector, 3, 4, 5 months, and then stopping, rapidly regaining the weight that they've lost, and sometimes, ultimately ending up metabolically more unhealthy than when they started. So that, there is a challenge in terms of how can we help people access specialist weight management services in order to access these treatments. Next slide, please. Well, and I'm delighted to say that Oviva are helping with that challenge, in that we have made our Tier 3 weight management service available to all patients in England under the NHS Right to Choose legislation. So this is a relatively recent development. And what do we mean by the Right to Choose legislation? Under the NHS Constitution, and I think we are quite familiar with this as GPs, under the NHS Constitution, as a patient, you are legally entitled to choose which provider delivers your consultant-led specialist treatment. And that doesn't always have to be the provider that is geographically closest, although we know that often patients do choose the closest provider. And we're very familiar with that when it comes to common surgical procedures like a cataract operation or a hip replacement. But it applies equally to consultant endocrinologist-led specialist weight management care. So what that means is that if a patient with their GP is felt to be suitable for referral to a Tier 3 weight management service, that patient can choose to be referred to Oviva's Tier 3 weight management service. And because we are a remote provider, we can support people living in any part of the country. And for us, as I say, it's relatively recent development, although not surprisingly, we're starting to see a significant interest in our service and a significant volume of referrals. It's exciting because what it means is that we can now try to help improve access to that comprehensive, holistic, multidisciplinary, high-quality Tier 3 care for the patients who need it, regardless of their level of affluence. Next slide, please. So how do you refer to the service? It's very simple. Ultimately, you need to complete the referral form, which has minimum requirements that can be found at oviva.com/refer. Also, pleased to say, auto-populating versions of the form are available through Ardent for both System 1 and EMIS. Once the form is completed, you need to send that either through NHS Mail or through ERS. Next slide, please. So that is it for this session. I just want to do a bit of a plug for next week's session, which is, we've talked a lot about the psychological and dietetic elements today. We're going to go back to talking about the medicines next week, the next Thursday. We'll be joined by Wasim and Shane, two other doctors within our service. We're going to focus, because it's very topical, we're going to focus a lot on tirzepatide, what the new NICE guidance says, and also dig a bit deeper into some of the differences between Wegovy and Mounjaro. Just going to have a quick look at the Q&A. I'm going to let me just read this question. So, how often do you come across patients who perhaps develop less healthy relationships with weight loss, who have already started treatment, in brackets, perhaps not to the extent of being diagnosed eating disorders, and any tips on how you would approach this with patients if there are concerns? Maybe I'll pass that over to you, Vicki, if that's all right.
I don't know how I'm going to answer that in 3 minutes or a minute. I'm afraid it's a really good question. I think that being disingenuous, it's not something we get so much of at Oviva, because we've got a sort of two-prong approach with dietitians and psychology. So we rely heavily on our dietetics colleagues, I think for this as well, to really embed sort of healthy eating approaches. I do think things like the Bed 7 screener that we use quite a lot, which is freely available online if you search for Bed 7, is very helpful and is suitable for primary care, just to assess level. And I think it's about focusing very much, as Juliet said, on nutritional quality as well, and what the overall aims are for that patient and where they're going to be going with their weight loss journey. But if you wanted to pick this up with me separately, I'm sure Tara can get a message to me and I can answer a bit more for me.
Yeah, I think there's a lot to that question. It is a very complex one. So we are very happy to be contacted and to go into a bit more detail. And yes, there's another final question, which is around the session. A recording of the session will be made available if you've missed some of the start or want to share it with colleagues. And we're a couple of minutes over, although I think I'm seeing a well, I always like to finish with a positive. So thank you very much. You know, the comment reads, I really love this session and learnt about your services. It makes me so happy that England is doing something about obesity. This is amazing news. And I think that is a really positive sentiment. And it is important to recognise that even though we have some way to go, we actually are further ahead in England. You know, we do deliver services in Scotland and Wales, but we are ahead in England compared to a lot of countries in trying to address this challenge around treatment. There's a lot of focus on prevention, and there's a lot of work to do there, but this focus around treatment at the same time as prevention, we have made progress. So I think it is important to recognise some of the progress and some of the good things that are happening. So yeah, thank you for that positive comment to finish. Just to say thank you very much again for sparing the time to join us, and I hope that people have come away and have found the session interesting and have taken away new information that they can take into their consultations with patients. Okay, thanks very much.